MRD in AML is traditionally tracked either by a molecular marker for those cases where we have a validated molecular test and a pathognomonic marker, NPM1, core binding factor leukemias APL, and in all of the cases, flow cytometry. I think we're all very excited about the potential of next generation sequencing or ultra deep DNA sequencing to better stratify patients as a very specific marker. But the question's really been what targets are most appropriate for monitoring. We conducted a large nationwide retrospective study called the Pre-Measure study with over 1,000 patients in total, 608 of whom had FLT3-ITD at diagnosis, to work out for a particular context of use, those patients in a first remission going to a first transplant, how important was the detection of a persistent FLT3-ITD at that time point in blood. And the answers are really clear. Both in a discovery and validation cohort, the persistence of FLT3-ITD in blood was associated with massively increased relapse risk and worse overall survival after a transplant. Over the past 2 years, there's been a variety of studies now from many groups. We have at least 5 different studies, all confirming this same essential finding. The detection of a FLT3-ITD by next generation sequencing that's persistent in remission before a transplant is associated with worse relapse and higher rates of death after a transplant.